We've got a very busy program, so I appreciate that there's a lot of information being put into here. So bear with us if you can. There will be a chance for questions at the end, and there may be a chance for questions along the way. And to the speakers, I will give you a 2-minute warning, and then a time. If there's more time at the end, we can carry on discussions. I'd like to say, coming back, thank you to our supporters and sponsors. These evenings can't take place without support from many different people, and we like to think this is also a collaborative evening within the industry to help inform patients, and there's a lot of information out on the stands out there, and if people would like to talk to the sponsors and supporters, that would be much appreciated.
For any breast reconstruction, consultations, in the consultation you want to get a history. You want to get a history of the tumour, medical problems with the patients, and any previous surgical operations, so then you can help you make an assessment of what's going to be the right reconstruction for that patient. The examinations, not only examining the breast for the size and the shape, but also looking at the chest, looking at scars, the tissues and that, examining the back and looking at the abdomen. Once you examine both these assessments, you can sit down with your patient and do a proper discussion about what's the appropriate reconstruction for them. Now, what are your reconstructive goals? It's obviously recreate symmetry, create a natural appearing breast, but in so doing, preserving patient safety and their quality of life. In terms of creating symmetry, what are the key features? The size of the breast has to be the same. Position of the breast on the chest wall, the position down for mammary fold, that's the IMF. Ptosis, which is the droop of the breast, and projection. These are all important factors when you're assessing the patient. The options are do nothing. Reconstruction option, that doesn't have to be done at the time of the cancer surgery, it can be done later on. If you're going to do reconstruction, the options are to do autologous reconstruction, which other speakers will talk about, or else implant reconstruction. Prosthetic reconstruction or implant reconstruction was one of the first methods of reconstruction developed. With improving technology in implants, the quality of the reconstruction has improved significantly. So what are the pros and cons of expanded implant reconstruction? It's a shorter operation, because of that it's a quicker recovery. There's no other donor sites or cuts anywhere else in the body which can sort of prolong recovery. What's the downside of that? Implants don't look as natural as a normal breast does. There's a question mark about the lifetime limit. No one knows exactly how long these new implants last for, because they haven't been around long enough. Generally 2 operations are required. Once you put the implant in, it's a fixed size. As the patient puts on weight, or loses weight, the implant stays the same size, so that's the factor for some people. In the reconstructive process, once the expansion is in, obviously you need frequent visits for expansion, and there's implant complications. Who are good candidates for this? People who don't have any skin or fat, no donor tissue to use for autologous reconstruction. That might be for health reasons, where people are not very healthy and they can't tolerate a big, long anaesthetic, so this is a good choice for them as well. There's social reasons and personal choice. Best candidates are healthy for the patients, minimal droop or ptosis on the breast, and for bilateral reconstructions. And patients have to have realistic expectations. Candidates who are obese, large topic breast, or heavily scarred chest with radiation are not good candidates for expanded implant reconstruction. The surgery is a 2-stage reconstruction. The first stage of reconstruction is insertion of tissue expander. You mark your patient up preoperatively where you mark the inframammary fold. The dotted line represents where your expander is going to sit a couple of centimetres below the inframammary fold, and the nipple area complex is excised, and you excise that as an ellipse. Once the mastectomy has been completed, the plastic surgeon comes in and you dissect the pocket under the pec major muscle, a flap of tissue from the side using the fascia or the muscles elevated out the side. Your expander is put under this muscular pocket, you fill it up with some fluid, you close your muscle to the flap on the side, it drains in, and then the operation's finished at that stage. The timing can be done at the same time as the mastectomy or can be delayed. This lady had mastectomies done over a couple of years, and then she came forward with reconstruction. So she wanted to have expanded implant reconstruction, and that's a good result, just the way it turns out. The expanders themselves are basically balloons. They're silicone shells which we fill with salty water. The way we fill this is A port, which we fill it through, can be a remote port, which is a powerful port, you can fill it, whereas the port can integrate it into expander. The integrated port has got a magnet at the back, and that's how we find the port to inject the saline in to fill it up. The expansion starts 10 to 14 days after expansion. Expand 30 to 100 mils each time, depending on the size of the breast reconstruction you're trying to achieve and how much pain is tolerated and how much stretch there is on the skin. Expand on a weekly or fortnightly basis. Keep an accurate record of how much you're putting in. And once you've reached the intended volume, you can overexpand a bit by 10 to 30%. This is the expansion process. This is the magnet we use to find the port. X marks the point where the magnet points to, so that's where the port is. The needle goes in, directly into your port, inject your fluid, take the needle out. It's a self-sealing port. It's like going to a petrol station and being filled up. It's only about 5 minutes. We don't use unleaded, just saline. So stage 2 of the reconstruction is done 3 months later. You're determining the implant required in terms of shape and size. You also determine if you need to make any adjustments to the capsule pocket, and determine if you want any contractile breast surgery done at the same time. This lady can expand out, wait 3 months, have implants put in, nipples, reconstruct and tattoo. So that's what we're trying to achieve for our final results. The implants we use, they come in various shapes and sizes. There's multiple brochures and pamphlets around the different implants. But the main variables we have to deal with is the size of the implant, the shape of the implant, it can be anatomical round, stuffing meaning what's inside the implant, it can be like silicone or saline, and the surface of the implant is either textured or smooth. Textured implants seem to be the most common implant used. So in terms of shape, they're either anatomic or round. The majority of women have an anatomic implant, which is called a teardrop shape for obvious reasons, and anatomic for various reasons. They vary in their height and width. Round can go in higher low profile, which tend to be the less popular implants to put in. When it comes to the shell, this is what covers the implant. The more common implant shell is the textured silicone implant. An implant which is gaining popularity here in New Zealand now is the polyurethane implant. The shell is a polyurethane foam, so when you touch it, it's like a fuzzy foam. Because they're made in Brazil, it goes by the name of the Ferro Brazilian. Implants, which we commonly use anatomic implants, and they could be either polyurethane or and the silicone shell ones. They're both filled with a high cohesive gel. What do I mean by that? I mean, if I cut the implant in half, nothing happens. The gel just stays there. I liken it to biting into a Turkish delight. It doesn't leak out, it just stays there solid. And so that's where implant safety is improved a lot by the type of silicone that's used. So silicone gel implants are good, they look more natural and they feel more natural. What about implant safety? They don't cause immune problems, which was part of the problem back in the 80s, which they thought it did, and they don't cause breast cancer. The implant surgery, we do exchange and expand for the implant, is done 3 months after expansion. At this point, you excise the mastectomy scar, so you're not creating new scars. You just go to the same scar which the mastectomy was done through. At this point, you're trying to create the inframammary fold. You can see, look inside on, it's not much shape to your breast. So you have to develop that inframammary fold and the shape, curvature of your breast. You can do that once you go on to the same scar, take your expander out. Now do this by using internal sutures or using diaphragm to recreate this inframammary fold. With the implant, it close out. What are the complications of implants? This is the problem of implants. There's several complications. Rupture and leakage, this is a complication which may occur. Rupture by manufacturing error is very uncommon. Rotation is a problem, where if you distort the implant changes shape. Capsular contractures where you form a scar tissue around your implant, and this can cause problems. In 10 to 15% of women, this may need to be changed. Infection is very rare, it's only about 1 to 2% that occurs during the implant has to come out. Limited lifespan, we don't know how long these implants last for, but it's a lot longer than what the old implants lasted for. Small writing is ALCL, anaplastic large cell lymphoma, which has been found occurs with implants with reconstruction or augmentation, but the chance of this is extremely small, it's about 1 in a million. Here's some completed results. The right side is reconstructed breast, the right side Contractile breast, you may want to do surgery on the thigh breast, whether it be a reduction, a mastectomy, or augmentation. This lady had a reconstruction, one being augmented on the right, so put a bigger implant on the left. Reduction of the left breast, and the implant on the right side. This became popular after Angelina Jolie had this operation. This is used for prophylactic mastectomies to spare the nipple. It maintains a better aesthetic and natural nipple. Monitoring the breast can be done with implants for breast cancer, whether it be physical, it's a combination of physical examination, ultrasound, and MRI. Just a brief mention to get on the other talk. Latissimus dorsi, if someone's had radiation, delayed reconstruction, you can do a reconstruction using latissimus dorsi or the expander, go through the same process, expanding out on the final implant. She won't be augmented at the same time, so this is the final result.
Thank you. I'm not covering the same ground that actually elegantly covered, so we're really going to be looking at just the different types of reconstruction as we go on from here. Ashley mentioned that the common procedure worldwide is to actually use a latissimus dorsi plate, and I'll explain what that is in a moment, combined with an implant to get volume. But there is a newer, more updated way of doing the operation called an extended latissimus dorsi, which means you can actually do the reconstruction in many cases without the need for an implant. What is the latissimus dorsi muscle? The latissimus dorsi is Latin. It just means the widest muscle on the back. So it's a big fan-shaped muscle on the back on both sides. And when we're talking about an extended latissimus dorsi flap, we're talking about taking tissue with the muscle and outside of the muscle to give us enough volume to create a breast with it. A flap, and this will become a repeated theme over the evening, is a piece of tissue which has its own blood supply and is transposed to a new site in the body by various means, and those will be described to you, and so it carries its blood supply with it. So what is the standard latissimus dorsi flap? The standard, this is the muscle here, and there's an equal one on the other side. It's a muscle that most of us actually surprisingly don't use all that often. Pushing up from a seated position, rock climbing, holding us up like that, doing chin-ups, those are all latissimus dorsi actions. It's fair to say that most of us over the age of 30 hardly use it. And interestingly enough, when you take this muscle out, despite the fact that it's the biggest muscle in the body, most people don't even notice it's gone. If you examine a patient a year afterwards, you can measure that it's not there, but symptomatically it's not a problem. Now, normally when you're doing a latissimus dorsi flap that Ashley described, you take a small bit of skin with the muscle, and then predominantly you rely on the patient's own skin to provide the cover, and then you're using an implant for volume. In the case of an extended latissimus dorsi flap, we take a very, very much bigger piece of skin and fat, extends well outside the area of the muscle, comes round forward. I can't draw this three-dimensionally, but it tucks around onto the edge of the stomach and comes right up to the midline, just within the shoulder blades. But this way you can actually get a very large volume of tissue. The advantage of it is it's incredibly reliable and it is well vascularized. It's very, very uncommon for it to fail. Because it has good vascularity, it tolerates radiotherapy very well, and there's going to be a talk a little bit later in the effect of radiotherapy on breast reconstruction. Surprisingly for the size of the muscle, there's very little what we call donor site morbidity. So in other words, injuring that part of the body doesn't lead to long-term symptoms. And of course it avoids the implant complications that have already been described. The disadvantage is it does give a very large scar on the back, and that's something that many women don't particularly like, and they prefer other options in terms of transfer of tissue. It's not suitable for all women, but in fact it's actually suitable for about 70% in my experience. And of the reconstructions that I do, about 30% of them are purely implant-based, 30% of the complex reconstructions from the abdomen, which will be described later, and 30% are of this type. It is, however, fair to say that, as with most reconstructions, you get better results with immediate reconstruction than delayed reconstruction, and probably that's more true of this flap than of the abdominal flaps, which will be described later. It does tend to result in a little bit more volume on the outside part of the breast, That's correctable, but often needs a second stage to remove some of that volume to give a better overall shape. I'll show you some pictures of that. But in an immediate reconstruction situation, it can actually give you good volume and good shape. Obviously, the normal breast mastectomy on this side, and this is the donor site scar here. I'm not sure how well that picks up. Okay. So it's a fairly fine scar, but it's a big long scar. Similarly, you can get quite nice droop with this, with immediate reconstructions, and this is to show how far around on the side of the chest onto the top of the stomach the actual scar comes. Okay. And again, this is again a donor site scar, but again showing the tendency to get a little bit more fullness around the side here than you might otherwise expect. Again, that's easily correctable. Can be used for delayed breast reconstructions, and you can get a very large piece of tissue. Because you need the skin here to give you a drooping breast, that's why it's got this extra volume there. It comes with the skin. Again, this lady didn't want anything done about this, but could well have done with a little bit of revision there. And again, although she's got darker skin, and darker skin people tend to scar worse than pale skin, it's a fine scar, but it is a little bit pigmented. It will gradually settle over time, but will take very much longer in somebody with a paler skin complexion. And again, showing the degree of the scar going right from around there all the way up there. And again, another delayed reconstruction, again in a paler skin and much better scar. So it's a very suitable reconstruction for a large number of women. It's not suitable for everybody. It does have its drawbacks, but it's very reliable, and it is an option that's in our armamentarium.
Microsurgical reconstruction involves disconnecting and joining small arteries and veins, enabling a portion of living tissue, for example skin and fat, to be disconnected and transferred from one part of the body to another. In other words, this enables tissue from elsewhere in the body that is spare to reconstruct breast tissue which has been removed. The history of using microsurgery for breast reconstruction is relatively short. Plastic surgeons for a much longer period of time have been doing tummy tucks or abdominoplasties, and an American plastic surgeon was looking at the tissue that he used to dispose of following a tummy tuck and thought, can't I use that to reconstruct a breast? So he performed his first free transplant where he took the skin and fat and muscle from the lower abdomen to reconstruct a breast by disconnecting the blood vessels and joining them up in 1984. The next advance was when these surgeons described performing a mastectomy but leaving the skin envelope behind. You can imagine taking away the breast from the inside but leaving the skin envelope on the outside, and then that made a much more aesthetic or a much better looking reconstruction by filling that either with one autologous or an reconstruction. They also showed that this didn't affect recurrence, or it didn't affect the oncological or cancer side of the treatment. And then the third advance is what we call perforated flaps. And I'll talk about a lot more about those in a moment. But basically they enable one to dissect skin and fat through the muscle but without taking the muscle by dissecting the smaller blood vessels. First done in 1989, but popularised by Belden and an American in the late 90s. So what are the advantages? It's a soft, permanent reconstruction of your own tissue, no silicone or other material. A side effect is a tummy tuck, or if you're using other parts of the body, a thigh or a buttock lift. High chance of success in that if the flap takes, it usually takes, it all survives. However, a small percentage of them won't survive, but there are alternatives for reconstruction if that doesn't happen. Minimal loss of abdominal function, and can be used after radiotherapy, and can tolerate radiotherapy as well. The disadvantages, not as widely available, so it's usually available in bigger centres. It requires microsurgery and appropriate aftercare. As I said, if the flap's lost, then there's complete loss. It's a longer operation, stays longer, recovery is longer, and another part of the body is affected. There are two types. You can either perform this at the same time as the mastectomy or any time afterwards. So the mainstay of microsurgical reconstruction is using the abdominal wall or the tummy. That's because the skin and the fat of the lower abdomen is ideal. It's natural and natural in look and feel, and the tissue ages with the body and changes with weight fluctuations. This is just a schematic diagram showing this is the type of pattern of skin and fat that we take. That's the tummy button there. This is the muscle, the six-pack muscle, and there's a blood vessel that keeps the tissue alive, one coming from the top and one coming from the bottom. Traditionally, the traditional pedicle plan flap, which was the classic abdominal tissue flap before microsurgery, the flap is taken, connected to the muscle and tunneled up underneath. Now, with microsurgery, we can take the lower blood vessel and disconnect it with the skin and the fat, leaving the muscle behind, or taking just part of the muscle. That's what I just said there, and then it's connected up to either the blood vessel under the rib here or the blood vessel in the armpit. So this tissue would be the tissue that's gone from the tummy. There is a big long scar, and there's a little scar that will take on the skin behind. Perforated flaps just allow one to dissect the tissue with minimal disruption to the muscle. And the DIEP flap, which some of you may have heard of, is just a fancy name for the blood vessel that enters the flap. This is your six-pack muscle. If you split it, there's a blood vessel coming up into it, and there's the little branches that go through the muscle into the skin and the fat. So you can just take the skin and the fat and leave the muscle behind. That's important for the function because the muscle acts as an internal corset for your everyday, your core strength muscles. This is just showing it again. In a very small number of people, there's a blood vessel big enough to use that's just on the surface, where you don't need to use the muscle at all, and that's called PSIEA. For people who've had surgery to their tummy, or there's some other reason you can't use it because they're too thin, there are several other alternatives, including the buttock and the inner thigh.
So I'm going to talk about radiation treatment just in a very briefly, it could be more than a 10-minute talk, just in alone. It's also known as radiotherapy, and it's high energy X-rays that aim to get rid of any cancer cells that could be left behind after you've had surgery. So underneath the skin, on the chest wall after a mastectomy, or to the rest of the breast after wide line excision, or on the armpit, which we call the Acellular, after you've had lymph node surgery. And it's very effective in reducing the risk of cancer coming back. So who needs radiation? Well, every woman who's diagnosed with breast cancer will have their case discussed at a multidisciplinary meeting. So if we know that you have an aggressive tumour, a large tumour, there may be a recommendation that radiotherapy would be very useful. Your reconstruction is also individualised, and we probably recommend that you defer your reconstruction in this situation. So I'm having to make some generalisations. While your cancer treatment plan is individualised, so will your reconstruction plan. There are some women who may find out after their mastectomy and those results are analysed they need to have radiation. And I'll show you some examples of women who've been in that category. I can reassure you that it's possible to get a very good reconstructive result after you have radiation. And it's more likely to use the techniques that John Canary and Alessandra Canal have talked about, your own tissue. It may be that you need to have something done to your breast to get symmetry when you're unclothed, and it may take several operations. And generally we'd start the reconstructive process after the skin and soft tissue have recovered from the radiation. So that could be about a year after radiation is finished. So this lady is a typical example of what we often see and women who present to us after the radiation is finished. So you can see there is some hyperpigmentation or darkening of the skin. And you can imagine that if we tried to stretch that up for the reconstruction that Ashlyn talked about, the skin will probably get very thin. It's not as elastic as normal skin that hasn't had radiation. This is an example of a lady who had a reconstruction using her tummy tissue, the deer, at the time of her mastectomy. She then had radiation to it. So it used to be a very good volume and symmetry match to her right side, but now it's been lifted up and pushed to the side, and it's also shrunk, and when you touch it, it's a lot firmer. This is the reason why, if we know someone's having radiation, we'd like to delay the reconstruction. But we don't always see these bad results. This lady had radiation to one flap, but the volume hasn't changed. It may feel slightly firmer, but she doesn't have as bad an outcome as the previous lady did. As a surgeon, we've got a lot of respect for skin that has had radiation. So this is an example of breast skin that's had radiation and now has had surgery. And the blank areas of skin that's not very healthy won't survive. But in the middle where the skin is pink, this is skin overlying the muscle from the back, so that is healthy. So we take all of this into consideration when we plan the reconstruction to avoid complications. This lady had a right-sided implant placed. Then she discovered that she was going to need to have radiation treatment. So on the right, she is here 6 weeks after she's had radiation. So you can see she's got the radiation tattoos there, but you wouldn't know otherwise that she's had radiation. She doesn't have the darkening of the skin like I've shown you in other pictures. On the left, she is 12 months after radiation, and you can see that that implant has lifted up and it's been tightened or kept the contraction around it. Heard about the muscle from the back? You can take a small bit of the muscle or just the skin overlying it and use that to recreate a defect in the upper outer part of the breast that might result after a wide local excision. This lady has had that procedure. So on the right, top and bottom, here she is after she's had a wide local, just a biopsy actually, it's a biopsy scar there, the green node from a sentinel node. And then she had a wider excision. And you can see that if we took more tissue from there, the nipple might get pulled up in that direction. So on the left, we've got the skin from the back, filling that defect, and you can see the faint outline of the pigmentation from the radiation there. Lady I showed you before, she has 2 operations, the muscle from the back with an expander, and then an implant to get this result. This lady has the same technique I just showed you on her left side, so the muscle from the back, 2 operations, then an implant. At her second operation, she had a right mastectomy and the deer, the tissue from her tummy, used to make a smaller breast on the right. And so you can see 2 different methods, 2 different operations, can give you a good result in terms of size and symmetry. Bad result after radiation to an implant. On the right side, it feels very tight and uncomfortable. And you can see the skin is very thin, particularly around here where the implant is imminently going to come through the skin. So here she is with having had the tissue from both sides of the tummy. This may not look particularly attractive to you, but of all the patients I'm showing you tonight, this is my happiest one. This feels soft, it fills the bra nicely, so in clothing she feels very feminine. And we can go on and offer her more procedures to make them look more breast-like, but she is delighted at this stage. This lady has had a wide local excision, here's her scar there, and radiation to the left breast. And she's now come to have bilateral mastectomies and reconstructions using the tissue from her tummy. And here she is 6 months after surgery, and we've just done a nipple reconstruction for her under local anaesthesia, and she'll go on to have that tattoo. This lady has got quite a lot of radiation changes on the skin here. She's also going to have a bilateral reconstruction. So she's a good example of how the skin that you see on the breast looks different if it's a delayed reconstruction on the left, as opposed to an immediate reconstruction on the right, where you just see the skin from the tummy wall with a nipple and areola lines. And I've got several photographs just showing you her from different views. Now this lady had a very aggressive cancer, so a lot of the chest wall muscle was taken as well. And you can see she's got very thin, scarred skin from all the radiation. And we use her tummy tissue with a lot of the muscle in this case to give her a breast mound and to replace a lot of that damaged tissue. Sometimes you can make the other breast smaller to get a match. So this lady had the DF, the tissue from her tummy, as well as a breast reduction. You can also use a reduction technique to treat a small cancer in a breast that's large enough to have a reduction. So in here you can see the little pink dot is the cancer. This tissue is excised as it would be for a breast reduction. And then the breast gets reshaped, and you can do a reduction on the other side to give you a good image. Now, this lady had a wide local excision, or the cancer cut out from the left side, and radiation. And she's left with a difference between the breasts. You can see that this nipple is heading up towards the armpit there. So she finds when she wears clothing that her bra and her clothing just gets dragged across to the right by the heavier breast. But she just wanted to have a simple solution, so we did a reduction for her. So it doesn't look perfect undressed, but now in clothing, they may stay without. So in summary, it's possible to get a really good result after the cancer treatment's done, so after you've had radiation. And generalisation again, often that's going to use your own tissue.
My talk today is on acellular dermal matrix. We'll call it ADM for short. What is it? It's basically a sheet of collagen, but it's obtained from either human skin or animal skin. So the animal donors are either pigs or cows. There's also a variety that's derived from the lining in the intestine in cows. And I think there's a research group in New Zealand that are looking at a lamb substitute. However, we'll mainly deal with the human variety, which is called alloderm, or the pig variety, which is called permacol. These skin substitutes developed in the 90s to treat burns, but more recently they've been used as an alternative to the Latissimus dorsi flap. In fact, one of the most renowned breast reconstruction surgeons, Patrick Maxwell, has referred to it as Latissimus in a packet. It has, however, developed some problems, which I'll allude to later on, but another surgeon has also referred to it as the zombie sling. And by this he means it's dead when you put it in, it comes to life, and then it dies. So, acellular dermal matrix. It's created obviously in sterile conditions. The skin is taken as a thick skin graft, and then they strip off enzymatically the outer layer, which is called the epidermis. And then it's processed to remove the cells and as the associated antigens that would cause rejection. So basically what you end up with is a sheet of leather. In fact, it's probably the most expensive leather other than the bar stools in Larry Ellison's yacht. So it functions as a scaffold, and what happens is that over time the body's cells and blood vessels grow into it and literally take it over. So because it's got no cells in it, theoretically there's no rejection. There's supposedly no chronic inflammatory response, and there's no increase in scarring. It's useful both in combination with implants, but also with expanders, because it will stretch when it's put under pressure. So why do we use acellular dermal matrix? Well, it facilitates the accurate positioning of the implants. It increases the coverage of the implant, because although you saw in the previous slides that muscle is used to cover the implant, the chest muscle can only extend so far, and this literally acts like a hammock or a gusset in the lower pole of the reconstructed breast. It also stabilises the position of the inframammary fold. It also prevents the muscle elevating too high over the top of the implant. So as a result, we don't have to do such an advanced, such an aggressive dissection of the chest wall muscles. Patients recover a little bit quicker. There's a shortened operation time, particularly when you compare it with the flaps that have been talked about. and the patient is apparently more comfortable when the expansions are done. How does it work? Well, basically it's just like a skin graft in a way, but it doesn't have its own blood vessels, but it's an inert piece of tissue which the body literally takes over by tissue ingrowth, and eventually when you cut into it, it will bleed if you went back and did a further operation. So here's a patient who's already had a partial mastectomy on the right breast and radiotherapy, and then she's got lobular carcinoma, which obviously has a 25% chance of occurring in the other breast, so she's opted for bilateral mastectomies and reconstruction. This just shows you the dye, how it's got into the lymphatics. So the dye has been injected around the nipple to see whether, to find out where the sentinel lymph node is. So this is the left side. The incision is relatively long. It allows the breast literally to be lifted up off the muscle like a book. So here's the breast tissue being removed, and this is the pectoral muscle here. This is the pigskin version. So it's very pale, obviously. There's no bristles or, it just smells a little bit. It smells a little bit like cat's urine when you open it up. The advantage, I've used it for a while because it's half the price of the human variety. And it also comes in a more even and robust form, so it's 1 to 1.5 millimeters thick. So here's the expander, which is going to be used on the right side. Here's the pectoral muscle, and here it's no longer white because it's got a little bit of dye on it and some blood, and so that's the pig skin, which has been literally sewn between the muscle and the chest and the fold at the bottom of the breast. So here's the other side. There's the pig skin. Obviously, Mr. Goodhoff's a bit of a cleaner surgeon than me. Here's the drain, and we have to use a drain to take fluid away from the skin, beneath the skin and the implant. So if you don't do that, the fluid will prevent the tissue ingrowth and the survival of the ADM. So there's that side completed, and the other side has to be closed up. Here's another case, obviously a bigger mastectomy. In this situation, the alloderm comes in a number of sizes, but the insurance company is a little bit loath to pay for the larger size, so they basically cover, I think it's that piece there, so I think they pay up to about $2,000 for the alloderm. So in this case we had to join two pieces together because we were using a larger implant. It works well in patients that actually have smaller breasts. So you can see with this patient, one breast weighed 146 grams and the other 188. So pretty much an A-cup breast. On one side the nipple was preserved, on the other side the nipple was removed and the tissue was purse-stringed. So the disadvantage of this technique is you cannot introduce a very nice circle of skin like you would from the back or the abdomen to reconstruct where the nipple was removed. However, after time that fades, and overall, she has a nice symmetrical result. Here's another patient, didn't want a lengthy operation, wanted rapid recovery, so she could go trekking overseas. Those are her mastectomy scars, and underneath she has the implant plus the alloderm. This was the first patient I did. It was a patient whose identical twin had died of breast cancer, so she knew that she would be next, and so she opted for prophylactic mastectomy. These were large breasts, 600 and 642 grams. I put in a smaller implant, and this, due to inexperience, I only used one sheet of alloderm. So what happened on one side was that with the tension that the muscle was under, it literally lifted the implant up. So the implant's sitting higher on the left than it is on the right. And you can also see with the nipple sparing procedures there's sometimes a little bit of insult, vascular insult to the nipple, but this will recover. So what did I do about the implant being too high? I reached for the Botox, which is in most private plastic surgeons' refrigerators, and I pumped 50 units of Botox into the muscle up here. Sorry, let's go back. So 50 units of Botox, and within a relatively short period of time, the implant seemed to descend miraculously. Here's another patient, bilateral reconstruction, small breasts, inframammary fold scar, nipple sparing, and this is her afterwards. A little bit of asymmetry with the nipple position, but overall the nipple looks very good. Here's a patient, difficult patient because she's previously had breast lifts, so she's got scars on the breast around the nipple and going vertically. So she didn't want to be any smaller than what she was. So she's her breasts weighed 545 grams. They're about a large C to a D cup. This is the permacole. There's the permacole placed between the muscle and the inframammary fold, and the implant is underneath. And I used largish implants, polyurethane coated. She's got a rather ugly closure of the nipples, but that over time that softens and flattens. And in fact, I haven't got the photograph, but I've replaced that puckered skin with a skin graft. This patient I'm operating on tomorrow to exchange the expanders. So she's got expanders which I've gradually inflated to close to 400 cc's. She developed a very small leak in this right expander, so we've had to get her back more frequently to expand it. In fact, the last time I expanded her, I put 250 into that side. And so she's going to be reoperated on tomorrow, just reopen the scar and take out the expander and put the definitive implant in. This is a patient just to compare. She's had a latissimus dorsi on one side as well as the ADM plus the implant on the other. So no nipple there, purse string closure there, similar volume, but obviously different scars, and you know, obviously the morbidity, the pain and discomfort from the back. This patient's had 3 attempted reconstructions. She'd previously had radiotherapy, a partial mastectomy, she'd had implants, expanders, and what happened was the radiotherapy and the combination of the expanders thinned the skin. The implant at one stage threatened to come through the skin and had to be removed. So she's not just back to square one, but you're dealing with a very difficult wound healing situation here. So she's had a combination of the large latissimus dorsi flap and an implant, and also we've added in the acellular dermal matrix to try and reduce her risk of recurrent capsular contracture. So she's obviously very happy with the result. We've done a little bit of a touch-up later on with some fat grafting, but I won't talk about that. What are the complications? Well, the problem with this, because it's a foreign material, it has a higher risk of an infection. Out of 22 cases that I've done, I've had 2 patients where we've lost the entire reconstruction because of infection. They are at considerable risk of developing fluid around the implant. You have to leave drains in for a minimum of 7, if not 10 days. That increases the infection risk as well. For some reason, these patients do tend to have a higher risk of skin dying. They can also get a skin rash related to the use of the foreign material, and it may be due to the antibiotics that the skin is soaked in. We'll see with this next patient, she's very thin, she's got these folds, but these can be trimmed later on. Finally, a patient where the original reconstruction was creeping across the midline. We put some permacol in to try and stabilise it. However, she developed a very nasty inflammation, and in fact I had to go back in and take the permacol out. So I've improved the situation with fat grafting, but she's still got very thin skin and a palpable implant edge. And finally, I'd like to introduce St. Agatha, who's the patron saint of breast cancer patients. This is a statue I had commissioned for my office, and this is the sculptor. Thank you.
Right, well thank you very much Meredith, and thank you all to the speakers who have spoken before me. It's been a great experience because I think it's been so important that people have been very honest about what Reconstruction can do for people. I think it's really important when you're thinking about Reconstruction is that it is a journey, and what I like to say to my patients that it is work in progress. Yes, we like to get everything done as quickly as possible, but I think there needs to be the appreciation that sometimes things take 1, 2, 3 operations to get things right, and sometimes complications occur. So Meredith asked if I'd speak about nipple reconstruction, and I was just going to already talk about just sort of like finishing touches. So when I'm talking about reconstruction, it was already alluded to before that for a patient it has to be individualised. Now this young woman had breast cancer. Her criteria was she wanted 1 operation, she had to be back to work. And so we wanted to do in this situation is just to put an implant in. It's not perfect for her, but we had to fit it in with what she was wanting within her life, because her breast reconstruction is just one part of her life. Whereas this lady, her brief to me when she came to me was she wanted to be topless on Waiheke at Christmas. So the image on the right up there, she's got that's the biopsy site on the left breast. And then she's had the reconstruction with an implant reconstruction. And for her, because everything's going to be different for a different woman, she wanted to be in a top and she wanted to have nipples. You don't need to have nipples to complete a reconstruction, and again, it's the woman's choice. We can give opinions, but ultimately, the woman must decide what she wants for her reconstruction. So, if you look at this woman, she's had a transplant reconstruction of her right breast. And if you look at it critically, it's a nice result. She's got nice ptosis, she's got a nice droop, it's got a nice breast shape, it feels soft. Now, you could say, well, that's good enough. And for some women, it is good enough, and that's fine. But for her, she felt that it really wasn't complete. And it's a bit disturbing to hear that some insurance companies are now trying to say that they won't cover nipple reconstruction as it's not a requirement, which is absolutely appalling. Because for some women, clearly, a breast reconstruction is about having a complete breast. So, for this woman, she's had a nipple reconstruction, and when I talk about nipple, it's really just to clarify, you have the nipple, which is the bit that sticks out, and the areola is the pigmented bit around it. So she went on to have a nipple reconstruction, and there she was happy. She hasn't really changed the volume, she hasn't changed the shape, things like that. But for her, it has completed it. It's gone from a mound, which fills a bra, to a breast that she's happy to look at standing in front of the naked in front of the mirror. And so you can just see that how nipple reconstruction really will complete breast reconstruction. So there are different ways to reconstruct a nipple. I'm not going to go through all the different ways. I'll go through probably what I regard as the commonest way, the one that I do most often. So basically what you're trying to do with a nipple is obviously you're trying to create a 3-dimensional structure out of a 2-dimensional plane. So in this situation, This woman has had a transplant reconstruction on her right breast, and the left one has just had a reduction. So the first thing you do is, and often this is why you would delay nipple reconstruction, is because you want everything to settle. Because once you put the nipple on, it ain't moving anywhere. Alright? So therefore, that's why you'll do most of the reconstruction, allow a couple of months, let everything settle, make sure everything's in the right place, the woman's happy, and then you'll come along to do the nipple. Now, obviously what I've done here, I've taken an ECG dot, so that the person, we can stand and say, look, I think the nipple should go there, and then we stand in front of the mirror, and we say, yeah, that's right, it's a bit low, a bit high, so we work that out. The nipple itself can be done quite easily under low plane 7. So this type of reconstruction is called C-to-D flap, that's sort of irrelevant, but basically what you're trying to do in this situation is, this is where, because as we talked, John talked about before, flaps mean that tissue has a blood supply, because all tissues survive have to have a blood supply, alright? So this part here is where the blood supply is going to come through, and this is going to be elevated up. And so the way I like to think of it, if you take your hands and it's going to lift up, the side bits are going to wrap around each other, and that little hat's going to go on the top. You'll see that on the next picture. So this is the same lady. You can see how where those wings were, they've been directly closed. So that's where the little wings were out to the side here and here. And they've wrapped around each other. Okay? And then the little hat, which is the little circle there, that goes and flips on the top. Okay? Now the important thing is that, and why nipple reconstruction tends to be a little bit easier than a transplant or where you've taken your own tissues, is that you've got a lot of fat that you can actually bring along with that to give it some fullness. Now, the thing about the nipple reconstruction though is that with time they all tend to shrink down. So initially you tend to make the nipple larger than before. So in those first few months, if you want to win the wet t-shirt competition with Konami, that's your opportunity. Okay, so then obviously you make the nipple, but you've got to give it some colour to it. And the way that we do it is through tattooing, and that's the way that it's commonly done. If you go to the internet, which is a source of information for many of us, you will come across techniques where they talk about taking skin grafts from dark areas on the body, and those dark pigmented areas of the body are places you don't want to go to really. So there we have a nipple with projection and coloration with tattooing. So let's just again, here's another example. This woman has had a Latissimus dorsi fat reconstruction. And if you look at the image on the right, she's got a nice result, nice ptosis, it's soft, but it just doesn't look quite right, it looks like a mouth. Whereas now, when you put the nipple reconstruction on, it does complete it as a breast reconstruction. Again, that's what that will look like. And just as it's already been talked about by my colleagues, finishing touches mean sometimes, you know, you do your big operation, but to complete your reconstruction, you need to do some other things along the way. One way is a reduction that often, as in this woman here, her breast on the right has had a trans reconstruction. It's obviously a bit sort of bigger than the left, so you want to come back on and do a reduction on that side. Alternatively, this lady here has had a Latissimus dorsi on the right there. It's already a bit smaller, but that was the original plan because, again, when she came on, she said, you know, I've got breast cancer, bugger if I'm going to get something out of this, I've always wanted bigger breasts. So she's come along, she's had augmentation on both sides. And that actually fits in well because sometimes that augmentation does help to lift things and makes the symmetry better. So, these are sort of all the icing on the cake. This was a very nice cake actually given to me by one of my patients. There are other techniques. After tea, which we're about to have now, Michelle Locke's going to talk about fat grafting, which has been a very exciting addition to the skills of breast reconstruction surgeons. So thank you very much.
So I have both a clinical and a research interest, and my research is in the stem cells related to fat. So anytime that there's a talk to give on fat grafting, I always get to. So what is fat grafting? It's got several different names: fat transfer, fat injection, lipofilling. The word lipo is really just another word for fat. But basically it involves taking the fat from one area of the body and re-injecting it into another area. We don't just use it for breast reconstruction, it's got lots of different uses. But in breast reconstruction, almost predominantly, we take the fat from the abdomen and we inject it into the breast area. Fat grafting basically involves us sucking the fat out with a syringe. There's nothing terribly technical about it, I'm afraid. We process the fat as we need to, and everybody does it a little bit differently, and in honesty it probably doesn't matter. It usually involves some sort of a wash of the fat cells to get rid of any blood. Some people like to spin it down in a centrifuge to try and get a more purified amount of fat. And then we take that fat that we've processed and we put it back into smaller syringes, like the ones that you can see here. That whole syringe only holds 1 ml. And then we use those small syringes and very fine needles to thread very fine threads of fat into the area that we want to fill. We usually use a sort of crisscrossing pattern to get lots of different threads of fat into the area. From a patient's point of view, well, what does the surgery involve? It's usually a short day-stay case. So compared to the other great speakers who've shown you lovely talks on how to actually make the whole breast from your tummy or from implants, this is the little touch-up, fine kind of stuff. It's usually a general anaesthetic, but you can do it just with local anaesthetic and sedation. You get a small incision at the point that we take the fat from. So for most women, that's around the tummy button. There's a little incision there for us to get the cannula in to suck out the fat. You might have a stitch or two there. We put some local anaesthetic and some fluid into the area that we're going to harvest the fat from. So you can get a bit of bruising with that and a bit of swelling, but the local anaesthetic does mean it's quite numb when you wake up. And then you usually get multiple small stab incisions around the areas that we want to inject the fat. So those are very small, just enough for us to get the needle in, often too small for us to even put a stitch in. But we generally use more than one because what we want, as I said, was this thin threads of fat in lots of different directions, so often that needs to come from different areas as well. So multiple stab incisions. And there's not that much in the way of side effects. You can have some bruising and some swelling after the surgery in both the area we take the fat from and the area we put the fat into, but that does settle down pretty quickly, usually within about 10 days or so, like any bruising would. It's just some of the equipment that we might use, some quite big liposuction cannulas, some much smaller ones, and there's some fat in a syringe that's been sucked out with some smaller syringes to put it into. My interest is in the biology of fat grafting. I'm not going to really go into it much here, except to say that when we transfer this fat, it's not just fat cells that get transferred. It's all the other cells that live in that area too. So there'll be some vascular cells for the vessels, and there'll be some adult stem cells that are the cells that renew and make more fat. So when we transfer the fat, we transfer other cells with it. And that's important because for the fat to survive in its new site in the breast, it has to develop a new blood supply there. So unlike the flaps you've heard about that take the blood supply with them, the fat that we put in doesn't have any blood supply, and so it needs to go and find itself a blood vessel to get some blood from, which is one of the reasons that we put it in very fine, thin lines. Because you can imagine if you put a large piece of fat into an area, it's very hard for the blood to get into the middle of it and keep all that fat alive. Whereas if you put fine, thin threads, it's much easier for the blood to get to that area. And it is thought that the stem cells and the vascular cells that are transferred with the fat can help it create its new blood supply. Regardless of that, almost always some of the fat we put in is going to go away, just disappears because it doesn't create a new blood supply, so it dies off. It's hard to know exactly how much is going to be resorbed, maybe a third to a half of it even, sometimes more, sometimes less. So fat grafting is one of those operations that it's not uncommon to do it more than once. If we do a touch-up and we're not quite satisfied with put enough in, we can easily do it again. So as I said, it's not only just used for breast reconstruction, but as touch-up surgery in breast reconstruction, there's several main reasons that we would use it. One is if you've had an implant-based reconstruction, and often you can see or feel the edge of the implant, and we just want to disguise that. So injecting some fat can be a good way to sort of soften the edge of the implant so it's not so visible. Or I think Julian showed some photos where the skin over the implant was quite thin and there was some rippling, so padding out the area to disguise the implant. If you have a contour defect, basically a dent, either after you flap all your implant surgery, we can try and fill it in with that. Or we can actually use it to try and add some volume if the reconstruction is not quite big enough. So just to show you a couple of patients, this lady's had an implant-based breast reconstruction, but she's got, you can see these lines that you see here are actually the contour defects on that side. So she's had some fat grafting to fill that area in. It's not quite perfect, she's still got a little bit of a dent there, but it's a big improvement than before. So we're talking about subtle differences and touch-ups with this kind of surgery. Obviously she's had a nipple reconstruction as well, but we're not looking at that right now. Here's another lady who's got a defect basically in this area just above her areola there, so she's had some more surgery combined with fat grafting to basically fill in that little divot that she had there. And here's another one who's had implants in, she's had a nipple sparing, this is her incision down here, but she's very thin and you can basically see the edge of her implant all the way around the side here and around the side here. So it's quite obvious where her implants are sitting. So this is a great case to do some fat grafting into that area there to just disguise the edges. And she hasn't had her implants changed at all, but if you just look at the difference through this area here, that she's basically had this all filled in with fat to disguise the edges of her implants. And I am doing some research with fat grafting, and there are potentially more uses for this. One thing that's being looked at around the world at the moment is using fat grafting to treat the changes that Sarah Kiln was talking to you about after radiotherapy. It is possible that in a small number of highly selected women we can potentially inject some fat there to try and improve the quality of the skin after radiotherapy. And another area, there's a group in Melbourne who are actually trying to use fat to make the whole volume of a breast reconstruction. So the problem with that, as I mentioned before, is getting the blood supply into the middle of the fat. So there's a lot of research going in there to try and improve the blood supply so that a larger volume of fat can be used, not just small thin threads of fat, so that potentially fat can actually be used to recreate the whole breast, but that's a long way off at this stage.
What I wanted to do was, everybody that's spoken to you is a plastic surgeon, and every one of these plastic surgeons is capable of doing all of the things that have been presented. That's really, really important concept to register, because I've been assigned topics to talk to you about, but all of these surgeons are expert in all of those things that have been presented. And I thought this was an opportunity to kind of close things a little bit by trying to do a sweeper roll and maybe put together some of the things that have been said and balance up also the aesthetic things that we talk about, because we're very focused as plastic surgeons on the aesthetic imperatives, on getting things to look good. We're obsessive personalities usually, and we can compulsively want things to be as perfect as possible because that's what we want for our patients. We balance that against the oncologic imperatives, the cancer imperatives, because the treatment goals are pretty obvious, that we want to cure underlying disease while still preserving or restoring normal body image and not creating any new problems, and that's a tall order in anything in medicine. And a fundamental tenet of medicine is to first do no harm, which is what that first Latin statement says. And then the second statement, Meredith added to one of my talks many years ago, which is, and secondly, keep people happy or make someone satisfied or improve their lives, which is what plastic surgeons do. And so in that context, who should be considered for reconstruction? Well, this group of surgeons thinks that the answer is all women should be considered for reconstruction. That's our opinion. It wasn't that long ago, certainly at the beginning of my surgical career, when when within some parts of the surgical community the answer would have been on the other side of the spectrum from those surgeons, because it was felt, don't mess with it, just treat the cancer and we'll leave things be, and in 5 years' time we might be able to come back and do something. So things have changed a lot over 30 years. Who should have breast reconstruction is somewhere in between these two lines, because there are lots and lots of different reasons why one might not proceed with reconstruction. One of the most important ones being because the patient doesn't want it. Perfectly reasonable. But it's very acceptable for us to see reconstruction as appropriate in women who are younger, who have early stage disease, especially if they're highly motivated, and obviously in situations like prophylactic mastectomy. What's generally also accepted is that in some types of carcinoma, and fairly uncommonly we'll see inflammatory carcinomas, the nature of the disease is such that it's a really bad idea to try and reconstruct in some of these situations. And if someone's really sick and has had, 2 heart attacks and a stroke and has diabetes, it's not a good idea to prolong the surgery and add extra things in. If the patients are nuts, it might not be a good idea to go ahead, because they're not going to cope with all of these extra things. If the patients are unmotivated, if they don't want it, or if they really, really have unrealistic expectations, it might be questionable whether it's a good idea. And the last group is the patients with advanced disease, and so I'll kind of touch on that as I go through this talk, but I wanted to, as I say, sort of do a sweeper roll and fill in and recover a few of the things that have been said. In my practice over that time, out of these reconstructions, you can see the majority are using patients' own tissues. About 30% are sort of fundamentally implant-based. So within those two groups of reconstruction, plastic surgeons like where we can to use your own tissue. And these days, if we can use fat grafting as well, it's just added even more tools to our toolbox. Most of the time in my practice, taking tissue from the tummy as a pedicle flap is going to work with about half of my patients and be a good option. But that means that there's going to be lots of other patients for whom another choice will be best. And this lady has ample tummy tissue to do 2 breasts. And in my opinion, it was a bad idea to put her through prolonged complex surgery because of her obesity and the other risk factors she had, and we got a good result out of an expander implant. And that was a good choice for her. There's a thinner patient who doesn't have much in the lower tummy tissue, and she's been done with implants and tissue expanders like Ashwin talked about, and we can achieve that at a second stage operation where we replace the expanders with implants, a good result. And then John talked about the Latissimus dorsi, so if we've got a situation here where there are pre-existing implants, it's unlikely we're going to find that much tissue anywhere else on their body. We're going to have to use an implant, but we'll use Latissimus to give some cover to that implant so we don't see those edges and ripples and so forth. And that's that patient 7 years down the line with a good stable result. For my practice, about 60% of the time, the abdominal donor site is going to be the best one, and that's where Alessandro spoke to you about that, and with the perforated flaps. And the reason that we as plastic surgeons like the Latissimus dorsi or the abdominal donor site is that if we can use your own tissue and create a lifetime result that feels natural, that's a better outcome in the long run than implants. It's just that it's not always available. The complication rates for these more complex operations run higher. Well, they run high actually across the spectrum. It's just a part and parcel of doing surgery. There's an expression that if you want to make an omelette, you have to break eggs, and there's an element of that in surgery. When you're interfering and injuring patients, as we do, things can go not as we planned, because humans heal in unpredictable ways, bacteria can come into play, tissues can bleed and so forth. It's much more risky if patients are smokers, if they're obese, if they've had radiotherapy before, if they have scars on their body that make things more difficult. All these things are factored in, and all of these things are thought about when we're making our decision making. And that the background and the experience you see in this room of plastic surgeons, the things that we learn from our teachers and the things we learn from our clinical practice, let us make good clinical judgments on behalf of the patient and advise them. When we think about the operations like pedicle tram flaps, which on average take 4 hours, and microvascular flaps, which take on average 8 hours, we're into some fairly lengthy operations for those patients. And even if we do fancy microvascular flaps like this patient that I did in 2002, and put a microvascular flap on this side, we still want to get the best result we can, and so we'll come back and do some fat grafting and other things. Stephen said it's not, I think it was Stephen that said it's not a one-stage procedure. I always tell every patient, you're up for more than one operation if we're going to achieve the best results we can hope to achieve. So what about the patient who comes along with advanced breast disease? They're much more likely to be needing chemotherapy and radiotherapy. Is it really a good idea, and is it really reasonable to offer that patient reconstruction if she wants it? Now, I looked at the patients that I treated between 1996 and 2003, of which there was 355 reconstructions, and 250 or so of those were immediate, meaning at the time of mastectomy. And of those, there were 39 in the group that had advanced disease. And advanced stage disease is patients who have either a very large primary cancer or a cancer that involves the associated tissues like the skin and the muscle of the chest wall, or cancers that have already spread to the regional lymph nodes or elsewhere to the body. So within that group of 39 patients, there was a large proportion with very big cancers and others where disease had spread elsewhere. And in that group of advanced disease patients, which is the blue, you can see that when we chose reconstructions, we were far less likely to choose an implant. The vast majority were treated by some form of tissue reconstruction, perhaps with an implant as well. One of those patients had some slight delay to the starting the chemotherapy, but that was only of about 2 or 3 weeks, and the oncologist said it was of no concern or significance to that patient's course of treatment. So we were able to do these reconstructions and not interfere with them starting their cancer treatment, the post-operative cancer treatment. And when we looked at surgical complications, it was there's a little bit of an irony that as it happened in the advanced group of 39 patients compared to the 200 or so of earlier stage disease, they not only didn't have any more complications, they actually had slightly less, which was interesting. That's a group of patients with more advanced disease, so they're going to have poorer outcomes. There's going to be more patients that get recurrence of breast cancer, more patients that get it spreading elsewhere, and more patients that die of their disease. But the rates of these things happening in those patients was the rates we would expect with or without reconstruction. So that was reassuring as well. And when we compared the data in my patients with the studies that have been published from places like Harvard and Boston and the Columbia unit and others, we found similar rates of local recurrence of distant disease. So that was reassuring us that we were treating the primary disease, achieving reconstructive outcomes, but first doing no harm, not interfering with their cancer treatment and not making it any harder for them to get good outcomes. Were we satisfying those patients? Were we creating as good a results from the patient's point of view? And you know, we might think we've got a good result, but what does the patient think? And so, I can't remember who showed the patient, Sarah showed the patient who's the happiest patient she has in her practice. This patient on the right is the unhappiest patient I've ever had in my practice. So all 3 results are patients who've had, well, 2 out of 3 have had microsurgical reconstructions, but this is a patient who's had microsurgery and is really, really happy with what's happened. This is a patient with a similar outcome who's neutral about her outcome, and this patient's really, really unhappy, but nothing went wrong. And there was no real reason why. It just didn't meet her expectations. So nothing's ever going to achieve 100% satisfaction. And that's really important to consider, because what we're dealing with here is more than just the things that you and I see in the photograph. We're dealing with people in the way that they feel about things. Right from the start of my practice, when I started out at Middlemore, we constructed satisfaction surveys, and we would survey patients a year after surgery and ask them lots of questions about how they feel about their reconstruction, how their partner feels, how their life's going, etc. And I've got lots of things to present on that, but just in terms of this advanced group, when we asked them to score their outcome and say how did they feel about the quality of their outcome, they would score on average 4 out of 5 compared to early stage patients which were 4 out of 5. So in other words, we were getting just as good results in the advanced group. And if you asked any patient in this series, if you ask them, would you go through it again? 100 out of 100 say yes, I'd definitely do it again. That's not because we do things perfectly. I get complications, we have problems. Patients like, as I say, there's patients who are really unhappy. But if you choose motivated patients, if you select as best as possible the right operation, generally speaking, patients will say, I'm glad I did it and I've recommended it to others. So the conclusions are, generally speaking, it's better to use your own tissue, especially in advanced disease. And immediate breast reconstruction doesn't increase the risk or doesn't delay getting other treatments for your cancer. The disease progression rates are going to be higher because the cancer is more advanced. That's part and parcel of more advanced cancer. But the surgical outcomes of our breast reconstruction and the degree of satisfaction the patient has with breast reconstruction can be just as comparable with patients with early stage breast disease. So, you know, we sort of answered the question, immediate breast reconstruction should be considered for all patients, irrespective of disease stage, but the patient selection is critical. And so just to sort of reinforce this point about the experience of surgeons and this great collective experience you have here of all New Zealand trained surgeons, the comprehensive surgical training will give you a stable foundation of principles and techniques. All these things, these basic principles, we can then build our clinical experience on. And then if we're aware of all these different surgical techniques, we can make good judgments on behalf of patients and refer on to more experienced colleagues if we think it's something that's outside of our immediate expertise. Mastering those surgical techniques takes many years of clinical practice, but it lets the surgeon offer the most suitable choice to the patient. Let that patient make a decision, because ultimately it's the patient's decision whether she wants to go ahead with something like this or not. And, you know, plastic surgeons are the only specialty group in the field of surgery who are capable of fulfilling all these three roles because of the nature of our training.